Okay, timely presentation, COVID-19 variants of concern, reviewing the science and implications. I'm going to start with a land acknowledgement and acknowledge that the land on which I live and work is the traditional territory of the Wendat, Anishinaabeg, and Haudenosaunee, and Toronto's covered by Treaty 13 with Mississaugas of the Credit First Nation. I personally identify as a settler, and I acknowledge the importance of treaties. Here is my disclosure slide. And then I have no conflicts of interest to declare. And in terms of mitigating potential bias, the content and information is as evidence-based as it can be. Some of it are from newspapers, and all the references are at the end of the presentation. And I prepared all the slides. However, I do have to give credit to Dr. Jonathan Lee from Harvard Medical School because much of the content is from his presentation, which is available publicly. So I'm going to review how viral evolution occurs. It's really important for the concept of understanding new variants and variants of concern. Review what we know about the COVID-19 variants of concern, and discuss the implications to vaccination. So the main new variants of concern that we're talking about are called the variant B.1.1.7, and this is the variant from the UK, B.1.351, which first appeared in South Africa, and the P.1 variant, which first occurred in Brazil. And of course, we started hearing about these variants, I think as early as November, December, in the UK. So here is a news report that the Kent virus, which is where it started, is sweeping the world. And then after that, I think in January, we started hearing about the new variant in South Africa. And then after that, of course, we started hearing about the variant in Brazil, which is unfortunately, and sorry, Andrea, it's ravishing Brazil right now. And then more recently in the news, I think this has been the main focus in the news in Canada right now, that these coronavirus variants are testing the limits of what we once thought was safe in Canada. And Mark can really give us an account of that, of what's happening in the hospital. And how do these new variants occur? Well, viral evolution is always occurring for viruses. So if you remember what a virus is, it's a non-living microorganism that has RNA or DNA in the middle. So, you know, and for COVID-19, it's an RNA virus, and then it has proteins. That's all it has, is RNA and proteins. And so the proteins make up, for example, the capsid, the envelope, in the case of COVID, the S protein, which is used for binding into the cell. So the virus goes into the host cell to replicate. So of course it uses its host cellular material to replicate, and its own RNA or DNA encodes for the viral proteins, and it just makes lots of copies of itself. And as the virus replicates, mistakes are made in the RNA or DNA. So that a wrong nucleic acid gets put in, and it doesn't get repaired. Human DNA, we have 5 major DNA repair mechanisms and 2 minor ones. So we have 7 mechanisms to be repairing human DNA, while most viruses have none. So mistakes in the nucleic acid sequence are happening all the time as viruses are replicating. And so this leads to viral evolution and to the creation of new variants. And this happens with all viruses. So there are new variants of no concern. So, and then there's variants of interest. So you may have heard of that sometimes. And then variants of concerns occur when we have some concerning factors, which I'll go over. So again, all viruses evolve over time. And so here's the coronavirus, or SARS-CoV-2, as it's known. And so there'll be a mutation within the RNA. And then at some point, or what's happened here is this mutation encodes for mutations in the spike protein. So it's a spike protein mutation and causes significant alteration, which might alter transmission or the clinical manifestation. In fact, but actually SARS-CoV-2 mutation rate is actually slower than other viruses. You would think that because we're hearing so much about it that, wow, it evolved more than other viruses do, but that's actually not true. Influenza actually evolves much faster than SARS-CoV-2, and that's actually because the SARS-CoV-2 actually does have a little bit of proofreading ability within it. And to show this, Jonathan Lee showed this slide, which I thought was so interesting. And the nurse I work with, Catherine, this is for you. We both work in HIV. And so this is the genetic diversity of different viruses. And one of the reasons it's been so hard to make an HIV vaccine is because the HIV virus evolves so quickly. So on the left here is the evolution of an HIV virus over time amongst the population. On the right top is the evolution of HIV in a single patient. So the HIV virus evolves in a single patient, and actually each person has a different virus within them for HIV, which again makes it difficult to develop a vaccine. And then here's H1N1 in terms of its evolution, and microscopic here, 10 times less is the evolution of SARS-CoV-2. So all viruses evolve, and why is it becomes it's so evident and clinically significant with SARS-CoV-2? It has to do with the sheer mass and number of people who are getting infected. So in the hundreds of millions that are infected, and why the evolution is being seen to be more significant and have more of a clinical impact. And the SARS-CoV-2 new variants are not new. So I don't know if people actually, if you know this, but new variants actually occurred early in the pandemic. So when the pandemic when transmissions were isolated to Wuhan and China, the variant was this was D614 SARS-CoV-2 variant. And then when it started to spread, and so the D is, if I remember correctly, aspartic acid at the 614 spot of the amino acid sequence. So that's how that's read. And then when the virus started spreading globally, around at the end of February, March, there was a mutation that happened that changed the amino acid at the 614 mark from the aspartic acid to glycine. So actually this G614 SARS-CoV-2 variant is the one that took over in terms of global transmission. And why does a new variant take over? It's because it has easier transmission. So the G614 variant is more easily transmitted than D614. And when we talk about non-new variant SARS-CoV-2, it'll be this G614. So not a new phenomenon happening even in this pandemic. So why do we worry about variants of concern? What is a variant of concern? So a viral variant will be considered a variant of concern rather than one of interest if it leads to increased transmission, if there's worse disease and increased hospitalization, if there's increased mortality, or if there's worse sequelae and long-term effects, or if it can't be detected by our tests. So far, the new variants that we're talking about, so B117, B1351, and P1, and I'm going to show you the data on this, meet the top 3 criteria, so increased transmission, worse disease, and increased hospitalization and increased mortality. We have yet to know about worse sequelae, so I think we'll be looking to see that data. And it doesn't meet the last criteria, so these variants can be detected by our tests. So back to the UK variant. So what ended up, this is from public health in the UK. So if you see here, actually, there's all these different variants. These are all different SARS-CoV-2 variants that were occurring in the UK. And then in December, that's when the rates, the B117 started taking off in the UK. And then very quickly, you can see the daily rates skyrocketed in December, peaking in January. And I would say that this is where we are right now in Ontario and Canada, is in this big spike. And then on the right here, you can see that that also the dark purple is the B117 variant. It started becoming the main variant across all of England very quickly. And then by March, there were reports that the B117 variant was actually also taking over in terms of transmission across the world. And so you can see here on the right that as of March 23rd, 50% of the cases in the US were the B117 variant. And likely a variant that's more transmissible is the one that will take over as the dominant variant. And so likely what will happen is that it's going to be this variant, B117, that's going to be the main variant transmitted in different countries. So what's the concern about B117 variant? It is 50% more transmissible than the prior variant, the G614 variant. So that's significant, 50% more transmissible. It's more transmissible in children. So in the UK, they saw higher rates in children in the order of about 40% higher. So that's concerning. There's higher hospitalization rates. And then on the right here, there's higher, it's like, so the way to read this is, we actually, when they test for SARS-CoV-2, even in our lab, they test for it. They actually sequence this S gene, and if it's negative, it's actually identified as a new variant. So when you see S gene negative, it's a new variant. And then in our labs in Canada, if you have this S gene that's negative, that gets sequenced when the SARS-CoV-2 is detected, then they take that sample and do more testing to see which variant it is. So they do an initial screen of all of the SARS-CoV-2 samples, and if this S gene is negative, then they take those samples out and test them further. And so you can see that the survival, if the S gene was negative, is lower. And again, no issue with assay detection. Meanwhile, in South Africa, there were surges of COVID cases with a new variant of concern, the B1351. It really started in the West Cape, but then again spread rapidly all over South Africa. And here again, you can see that there's the whiter other variants, and then by end of November, the yellow is the B1351 variant. It started becoming the predominant variant in South Africa. And then, of course, we heard in the news about the new variant in Brazil, P1, and unfortunately, we have less data about this variant. Maybe we'll be getting a little bit more information, because I think many of you know that there's cases of the P1 variant in British Columbia, here in the Whistler area, and then also now in the Yukon. These new variants, why do they lead to worse disease? Why do they lead to increased transmission? Well, they lead to higher viral shedding. So there's higher viral loads and higher shedding with these new variants. So that's one reason. So another sort of tidbit to understand the microbiology of this is, you might see these in reports and it's confusing, but we talk about something called the cycle threshold, CT. And so if you have a lower cycle threshold, a lower CT, it means the opposite. It means you have a higher viral load. So you can see here for the B117, see the S negative. So that's the B117 variant. It has a lower CT level or score than the prior variant. So both here, and then this is the B1351. Again, the CT score is lower than the other variants, so higher viral load. So that's one reason with increased transmission, but also might be contributing to higher severity of disease. Sanjeev, this is for you. The NBA has provided interesting scientific data. I'm not sure if people know, but Sanjeev loves basketball. And you know that the NBA and most professional sports did daily testing in their players and a lot of the staff. And so the NBA was able to catch the shift from the G614 variant to B117. And so these are the individual players. And then when you combine it, you can see in the red, the viral load is higher in the B117 versus the non-B117. But not just that, the duration of shedding is longer. And then over here on the right, not just is the viral load higher, longer shedding, but the duration of symptoms and shedding are longer, are prolonged compared to the older variants. So transmission happens for a longer period of time, and actually is one of the reasons the COVID assessment centers have shifted from doing the repeat test after exposure from 5 days to 10 days. It's because of this data. You may have seen that when you've gone to the COVID assessment centers. Okay, the theory of how these new variants of concern occurred, this hasn't been confirmed, but apparently this is what we do know. It's an evolutionary leap. So here again is phylogenetic. So each line and then the dot at the end of the line is a new variant. And you would think that it would kind of happen slowly, like over here, or where like here it's slowly. But actually for the B117, it was this massive leap that led to its evolution. And same here is the B1351. it was an evolutionary leap, much longer line. So quite a bit different. So the length of the line is how different is it from the variant before. And then you can see here on the right, the number of mutations across the genome, and these variants have a lot more mutations than the older variants. And the most likely theory is that these variants of concern occurred because of prolonged viremia in immunocompromised individuals. And so there have been case reports in the UK, and this is one from Boston of a patient with, I believe it was leukemia. And actually what's interesting is that it's B cell immunodeficiencies. The B cells is what's really important in tackling COVID-19. So unlike, for example, in my patients, it's the T cells are affected, and actually people with HIV actually don't acquire COVID more than other people, and that's probably because it's really B cells which is the essential immune cell for COVID protection and resolution. So here's a patient who had prolonged viremia for 150 days and going. So and had a B cell immunodeficiency. And then what's presumed is viral evolution occurs in these individuals, and then the evolutionary leap happens, and then that virus gets transmitted to somebody else. But it hasn't necessarily been completely proven, but that's the theory. Okay, do the vaccines work against these new variants? Well, not all variants are the same, and not all vaccines are the same. So, so here is this is data from the Moderna vaccine, and actually Pfizer did their test, and it just came out a couple of weeks ago. That in terms of, and I would say, I would think that messenger RNA vaccine data can be applied to both Moderna and Pfizer. But in terms of messenger RNA vaccines, there was this is the in terms of the response, there was no difference. So in the 614G variant or the B117, the same response in terms of the Moderna vaccine. So that's good. And then in terms of the B1351, there was a decrease. So it's about a 2.5-fold decrease in the response of the Moderna vaccine here, but however, it's still above. This dashed line is the threshold that you have to be above for the vaccine to be effective. So even though there's a decrease in the response, it's still above the threshold. But vaccines are also not all created equally. So they tested the Janssen, so the J&J vaccine in the U.S. and in South Africa. And while the response rate was a little bit higher in the U.S. For moderate to severe disease at about 72%, and versus 62% in South Africa, it was still effective. So that's good news. And just a slight decrease for severe disease. So the J&J single dose vaccine was 85% effective at preventing severe disease, and like 82% in South Africa. So the J&J vaccine is still effective against B1351. However, the AstraZeneca vaccine is not effective against the B1351. So they were rolling out the AstraZeneca vaccine trial in South Africa, and I'm sure we all saw it in the news, they halted it because you can see here in this Kaplan-Meier curve, these are the number of cumulative cases of COVID-19, no difference. So the AstraZeneca vaccine does not work against the South African variant. Why is B1, I think 351 so much worse? I think I reversed the numbers there, but that's okay. It has to do with the location of the mutations. The mutations are in the right area where the spike protein would be bound to the neutralizing antibody. So this top mutation, the N501, is mutation in all three of those variants. So the B117, 1351, and P1 have this mutation. But what the B1351 and P1 have are these additional mutations. So you can see here is the neutralizing antibody here, and you can see where the N501 is. And then, but look right here where the E484 mutation is. It's right where the neutralizing antibody would bind. So that's why the vaccines will work less, but also why the diseases are worse, because the antibodies don't bind to it well and don't prevent worse disease. What's happening in Canada? Okay, so this is from, I don't, you maybe know, but CTV has actually really good tracking of COVID across Canada, and so the light brown are all the numbered screens, and then the dark brown is the B117. So I would say across Canada, the B117 is probably around 30–40% of the variant that we're seeing now. And that's a little bit different in Ontario. In Ontario, this is the report up to April 11th. So the blue is the variant of concern, and then the black line shows the percent of cases that are variants of concern positive. So in Ontario, 70% of the SARS-CoV-2 that's being detected are variants of concern. And then you can see here in Ontario that it's really predominantly B117 and not B1351 and not P1, although there's been isolated outbreaks of P1 in Ontario. And then I'm sure many of you also know about the Ontario COVID-19 science table, which I understand is releasing a report today. I'm not sure if it's out already. I haven't seen it with the projected models. But this is the big concern, is that the new variants of concern have a higher reproductive number. So if you remember, the reproductive number is for each individual who has SARS-CoV-2 infection, how many people will they infect? And so its reproductive number so far in Ontario has been 1.23, while the earlier variants are lower at right now at 1.12. And we were able to get the reproductive number to less than 1 fairly easily with the prior variants. It's not all bad news. So here is there is reason for optimism. We are in a dark stage right now in Ontario because we are on the rise. If you look at the sort of red pink line is the UK, we are sort of in this phase, but with strict lockdowns and infection prevention and control measures, we will get to the peak and decrease. And so the United States, United Kingdom, South Africa, all of their severe, these are all wave 3s if you see. So they all decreased. And in fact, the UK opened from their lockdown Monday of this week. So hopefully we will be there in a couple of months also. So in summary, there are several new variants of concern. The one that's mostly affecting Canada is the B117 from the UK. They do look to be significantly more transmissible, cause more severe disease with more hospitalizations and mortality. The messenger RNA and protein, I didn't present on the protein vaccines, but because they haven't been approved yet, but they actually have very good response. They work quite well against these new variants. There may be some decreased efficacy of adenovirus-based vaccines so far to the B1351. And the most critical thing right now in Canada is are swift public health measures including lockdown and rapid dissemination of COVID-19 vaccines, and that this is really essential in Canada to curb the intense new variants. And here are the references, and we'll post the slides. And anyway, thanks so much.